Hi, my name is Wainberg. I'm a professor of medicine and surgery at the UCLA School of Medicine, Los Angeles, California. The topic of biomarkers in gastroesophageal cancer has gone through a lot of changes in the last few years. We have seen now that over the last 3 years, we've expanded what biomarkers should be tested and at what time frame in patients with gastroesophageal cancer. So for 10 years, we've known, based on the TOGA study, that we should be checking for HER2 status, which is overexpressed in 15% of patients or so. And based on the fact that we would add trastuzumab to chemo as a frontline therapy if they're HER2 positive. We now know, in addition to HER2, we should also be checking every patient for MSI status, because we know that instead of chemotherapy, we ought to be considering upfront checkpoint inhibitors such as nivolumab or pembrolizumab in upfront patients with gastroesophageal cancer as well. And thirdly, CPS scoring. And CPS scoring, which is composite positive score, which is a measure of PD-L1 staining, should be checked in every patient now with gastric and esophageal cancer, in my view. Now, we know that recent studies, such as the Checkmate 649 study and the Keynote 590 study, have suggested that regardless of PD-L1 status, these drugs are approved in combination with chemotherapy upfront in patients with metastatic disease. So when we talk to a patient who's newly diagnosed with gastroesophageal cancer, we look for 3 important biomarkers to summarize. First, HER2, then MSI status, which can be tested via MMR IHC proteins, and thirdly, PD-L1 scoring, which can also be tested via immunohistochemistry. So those 3 are the most essential that I would recommend in any patient that walks in the door with gastroesophageal cancer that is metastatic. Now, I will say that there are many new assays that are testing beyond that, because there are some biomarkers which have promising results in phase 2 studies, such as Claudin, which can be tested via IHC staining, or FGFR2b, which can also be tested via IHC, or FGFR amplification, which can be tested genomically. And if we can get a sense via a genomic picture of which cancers or which mutations are upregulated, which alterations are seen, that can also help us to find the more obscure targets. But when we talk to patients, we should always think about what are the most essential 3 things, biomarkers that, based on the current data in 2021, are essential, and that includes HER2, PD-L1, and MSI testing. Beyond that, many of them are considered still experimental, and we are waiting for phase 3 results to confirm the phase 2 benefits of those agents before those assays are routinely available. I will say that, as I alluded to earlier, some people will use these drugs regardless of PD-L1 status. For example, use PD-1 inhibitors in gastroesophageal cancer, regardless of PD-L1 status, based on those 2 large randomized phase 3 trials that led to FDA approval of those drugs. But it still does provide useful information for second-line therapy. It still does provide useful information for determining whether the addition of the checkpoint inhibitor adds much value to chemotherapy. The higher CPS score, the more likely they are to get benefit from the checkpoint inhibitor. Finally, with respect to HER2, we know that not just is HER2 now a target in the first-line setting, but is also a target in the second-line setting, based on the recent Destiny Gastric 3 trial that DS8201 met its primary endpoint of improving response rates compared to control arm chemotherapy in second-line HER2-positive metastatic gastroesophageal adenocarcinoma. And as a consequence, DS8201 is approved. So we do think HER2, beyond just frontline, but also in second line, is important to test. So based on that, those are the totality of the biomarkers that we think ought to be tested on every patient walking in the door.